Okay, so I'm hoping everyone can hear me. Is there a way to know if there's people here? Sorry, I didn't check that before we started. Um, so unless anyone tells me not to, I will begin. So, great, people are putting messages on the chat. Perfect. So, firstly, just to introduce myself, and yeah, welcome everyone first, and thanks for joining. So my name's Jess, and I work as a consultant psychiatrist in North London. But I'm also a member of the Planetary Health and Sustainability Committee here at the Royal College of Psychiatrists. And I'm very pleased to be here today to share what's going to be a really interesting webinar. So as you are likely aware, this webinar follows on from the recent launch of the Net Zero Mental Health Care report produced by the college along with Greener NHS, which provides guidance and recommendations on providing more sustainable and greener mental health care with the move towards net zero. So in this webinar particularly, we're going to be showcasing two contrasting examples of how to reduce carbon within the care system. So firstly, an example from a clinical care pathway at Hertfordshire Partnership NHS Foundation Trust, and who will be discussing the benefits of medication rationalization and de-prescribing with a particular programme that's been rolled out across dementia inpatient wards there. And secondly, an example from the Solihull Mental Health NHS Foundation Trust and their work on food waste reduction. So just to highlight, both of these examples link to specific recommendations that have been made in the report. So firstly, with regards to medications, so reducing emissions associated with medicines, that includes embedding net zero into medicines procurement, through to more sustainable prescribing practices and reducing medicine waste. And with regards to food waste, that links to the recommendation to improve energy efficiency across mental health estates and facilities, including recycling and waste management, and also to provide lower carbon food choices for patients and staff. So I hope that seeing these specific examples today can bring to life the recommendations and help provide inspiration for practical steps that can be taken forward. So to move on to what we've been waiting for, so our first set of speakers. So firstly, there's Dr. Bharat Balani, who is an ST4 psychiatrist currently working in North Central London. He's, however, going to talk about work he completed during core training in Hertfordshire. And this work was completed alongside Dr. Catherine Witter, who's a ST6 older adult psychiatrist in Hertfordshire as well. She's also a current Green Scholar with the Planetary Health and Sustainability Committee at the college and a core member of the Environmental Sustainability Steering Group for her trust. And within that group, the aim is to establish a coordinated approach to managing environmental impact of the trust activities, promote sustainable healthcare, and support delivery of greener models of care. I was quite struck in Bharat's bio about his enthusiasm about kind of de-prescribing, and particularly mentioning how it underpins all four of the core ethical values of practicing medicine, so beneficence, non-maleficence, autonomy and justice, and particularly relevant being justice, which refers to the fair and equitable distribution of healthcare, going on to say that if sustainability is not factored into healthcare and prescribing decisions, ultimately the system will eventually fail in providing an equal service for all. And that's why research into this area is so important. And I think it's good to hold that in mind as I hand over to both Bharat and Catherine to talk about what they've been doing. Just before I hand over, any questions, do please put them in the chat as we go along. And then once they've finished presenting, we'll go to the questions and have some time to field those. Great, I'll pass over to you both.
Thank you.
Thank you. Thanks, Jess. I'm trying to share my screen and start the slides going. 1 second.
Great.
Right. So is that coming up, Jess?
Yep, that's coming up. That's great.
Yeah. So my name's Bharat. I've here with Catherine today. I'll be talking through the slides mostly, but we're both here to answer questions towards the end. So put all your questions through in the chat box, and we're happy to have a bit of a discussion afterwards. So I've got until about 11:40, 11:45. So I'll spend 20 minutes or so talking through our project and then leave 15 to 10 minutes for a bit of a discussion at the end, because it can be quite a thought-provoking topic when I presented it elsewhere. While I'm doing this in the first slide, would people mind just writing in the chat what profession they're coming from, what background, just so that I can target what I'm saying? I don't know how many medical professionals we have here, how many non-clinical. So if you just write that in the chat, I've got it up here so I can keep an eye on that. So our project is focusing on inpatient dementia wards. So that's for people coming in to an inpatient ward because of behavioral and psychological problems associated with dementia, who require that level of inpatient input. In Hertfordshire, we have 4 of those types of wards across the trust. So we've carried out this de-prescribing project on I think 3 out of the 4 wards. So I can see we've got psychiatrists, sustainability practitioner, mental health nursing, pharmacist and sustainability pharmacist. Okay, thank you. That gives me a really good idea. Thank you, everyone, for putting that in. So I've got a bit of a sore throat, so I'm going to restrict my tone a bit. But I'll take you through the background to the project, some of the ideas behind starting it, how we implemented it, what we managed to achieve, and some of the thinking that leads from that project and the thinking going forward about what we want to do now. So this slide is essentially saying what everyone knows, which is that polypharmacy is bad and overprescribing is common, and it has an effect on patients. It's also saying that we have the Royal College position statements on sustainable mental health care. And the essential message is that in this situation, the clinical goals and the sustainability goals perfectly align. So it provides a really good opportunity for us to quickly and really meaningfully impact our sustainability goals and initiatives through de-prescribing. So the aims of the project when we sat down was to improve de-prescribing and medication rationalization in people with dementia on inpatient units, and also to adhere to the Royal College plan for sustainable healthcare. And that really came out of basically going through loads of drug charts and rewriting them on Friday afternoons and wondering why everyone's on so much medication, but realized this is a ward that's led by a psychiatrist, a consultant psychiatrist, and we're not really having those discussions about all of the patient's medications in the context of dementia, and we probably could be. So I think there's just a bit of an opportunity there. So I'll take you through briefly the kind of nitty-gritty of the project. And the point of this is that we've got project starter packs that we can communicate with other trusts about and send out and work with them to initiate similar projects wherever they are. So I'm just going to give you a background of what guidelines we used and our thinking. So there's a stop frail guideline. They're different to this very commonly known stop start guidelines. I think most pharmacists and clinicians would be aware of them by now, but they were developed in 2021 by a group in Ireland, which is the same group as those that developed the stop start guidelines. So they did literature review of the evidence base. They're well validated using Delphi consensus methodology, and they asked psychiatrists, geriatricians, in that Delphi consensus, and they've been rated to have a good inter-rater reliability and successfully rolled out in RCTs. So the inclusion criteria for patients to come under the scope of these guidelines are 3, and all 3 must be present. So the patient must have either a high dependency for activities of daily living, or a severe chronic disease or a terminal illness. They must also have severe irreversible frailty, and broadly, that's kind of a high risk of acute medical complications. The guidelines don't specify any tools to use for assessing frailty. And it's generally accepted that frailty is a clinically recognizable state, and experienced physicians know it when they see it. But we use things like the Rockford classification to help us out. And number 3 is that it's this surprise question. So it's that the physician overseeing the care of the patient would not be surprised if the patient passed away in the next 12 months. And underpinning all of this is shared decision making with the patients and the carers and the family.
And when we assessed each patient as to whether they fitted into these criteria in order to be included in our work, we sat with the MDT. So it was an MDT decision because we are aware that often the consultant on the team is only seeing them once a week, but the healthcare assistants and the nursing staff and pharmacy are seeing them every day. And so in these decisions, we made sure that we were including everybody, and making sure that this wasn't one person making a choice. It was using all the information that we could get from the team around that patient on our wards.
Yeah, and it's important to say that, at this, it wasn't really aimed at capturing palliative patients. As you could argue philosophically the definition of what palliative means, but it was, people captured by these criteria could be palliative, but not necessarily. So that last surprise question isn't a prognosis of passing away within 12 months. It's a general guidance. And the idea was to capture patients who are severely frail, who may not have many years to live. And it wasn't all the patients on the dementia ward. This is the summary. It's quite small to read, so I've just put it up here for illustration. This is the kind of summary page, which we ended up having in ward round and laminating, so that we can have it in ward round and in the pharmacy office, which summarizes how the guidelines work. Essentially, there's 3 main questions at the top. Can you see my cursor, by the way? You can. Okay.
Yes.
So there's 3 main questions at the top, which are general questions in section A. So it's drugs that patients are failing to take, or there's no clinical indication for, or their symptoms have now resolved. And then all the other sections are by body system: cardiology, coagulation, CNS. And for each system, they give specific guidance on types of drugs that need to be stopped, essentially. And just to go into one of them in a bit more detail, for example, you've got the cardiology section, which says that basically all statins need to be stopped, because statins are based on a 10-year risk reduction in cardiovascular events. And the patients that are meeting these, coming under these guidelines may not generally have 2, 3, 4 years to live. So there's really not much evidence that giving them statins would make much benefit. And a similar thing here with blood pressure targets. for frail older people, generally the evidence is different to those to adults, where a higher blood pressure is more acceptable and can sometimes be beneficial in terms of falls prevention. And there's some evidence about cognitive benefits as well in maintaining a higher blood pressure. So some of those antihypertensive drugs that they had been on can also be stopped. So that's just a general example. So in terms of the method, just checking the time, the method, what we did it differently on each ward. So when we conceived the idea for the project, we did it quite detailed on our own ward, where myself and Catherine were in the MDT ward round meetings anyway. So we gathered information from the staff members, the pharmacists, the MDT, did some research about the Stop Frail guidelines, and then we implemented the change ideas, which were to discuss this at have the guidelines present in the ward round meetings, have the pharmacist also screening separately for the drugs based on the criteria, and to discuss it as an MDT when we're going through our ward rounds. Then when we have CPA meetings, to also make sure that we discuss these, because it's a good opportunity to bring in the carers and the family. So we implemented it in that way. And we kept record of all the drugs that were initially prescribed on the drug charts and the ones that we stopped and why. So with the 3 wards, because it was done in the ward round, we involved all of these key stakeholders. In one of the wards, they had quite a good GP presence, so the GP was involved on all the decisions as well. But the other 2, we didn't really involve the GP unless there was something specific that we needed to ask. So with the first ward, we were involved quite heavily. With the second ward, what we did we gave a talk about these guidelines and how we did it, and then came to help them in a couple of ward rounds. And in the third ward, we just gave a talk, gave them the starter pack, and allowed them to get on with it in whichever way is appropriate for their ward. Gave them all of our data collection tools and our, and let them get on with it. So the purpose of doing this was because the idea is that hopefully this can be translatable and generalizable to other wards across the nation. So to be honest, the results, I was expecting to de-prescribe quite a lot, but when you see them in numbers, even on this smaller scale, it never fails to surprise me, because we've got, on all 3 of the wards, we had 50 patients, 30 of them roughly met the inclusion criteria. So we've got 30 people with dementia, who may not live for more than 5 years, likely, at that stage when they're being admitted for inpatient. They had 283 medications with a mean of 9 medications per patient. And we managed to stop a third of them, essentially, and which is a mean of 3 out of 9 per patient, which I think is pretty huge. And if it's not being done already and can be done, we should be doing it. So we're quite successful in stopping the medication. Just a quick slide on the types of medications that were stopped, if people are interested. So I'm just moving things on my screen, sorry. So on the left, we've got drugs that are stopped by the category. So you can see the biggest one were the obvious one, that symptoms are resolved. And then the next biggest one was the cardiology category, things like statins, hypertensives. If you look at this bit, this is a CNS drug. So those are drugs that you might expect a consultant psychiatrist to be doing already. So, your zopiclones or your antipsychotics or mirtazapine or whatever. So those are things that across the country probably is being done, but we're not sure. But what's interesting was same with the symptoms resolved. You'd expect people without this intervention to be able to tackle this. But what's interesting, I think, is these more physical drugs, GI, that's the PPI, the omeprazole, MSK drugs, cardiology drugs, which I don't think anyone is actually tackling at the moment in this psychiatric-led inpatient settings. And we've managed to develop an intervention that supports clinicians which aren't medical specialists to safely and feel confident to make these changes. So I think that's the interesting bit out of this. And as you can see on the right, the actual drug stopped. You're looking at statins, antihypertensives, PPIs. They're not stuff that ordinarily, without this intervention, psychiatrists are stopping in an inpatient dementia ward. So I think that was quite a good result. Catherine, did you have anything you wanted to jump in with? No? Okay. So what have I got? 7 minutes. So this is the interesting bit. So addressing frequently asked questions we came across from carers. I've given this talk now, trying to spread it in many different types of meetings. One of the things is, does this amount to discrimination against older adults? And I would say no. It's about emphasizing the good medical practice, making the patient our first concern. So the reason why it's so important for older adults is because many medications haven't been extensively trialed in elderly people or people with dementia. It's usually an exclusion criteria for RCTs. And when they they often can show a lack of efficacy or unexpected adverse effects. Physiological parameters like HbA1c, blood pressure may not have the same predictive value in this patient group. So it's really important that we target and look specifically at older people. It's not a discrimination thing. The other question was, is it not the GP or geriatrician's responsibility? And it's not solely their responsibility. We've got the patients with us usually for weeks, and it's a really good intervention point for us to make a meaningful difference for them. Patients and family members disagreeing was a bit of an anxiety thing. Even when we're carrying out, it depended on the consultant, and that is something that we always said we would have, and the guidelines said it emphasizes shared decision making. So if there are disagreements between family members, we were always going to have a low threshold for continuing the medication if it wasn't doing obvious harm. But we found that most welcome medication reduction. On our ward, we didn't have any difficult discussions where they were really opposed to the changes we're making. Most were welcoming it. Most people, if you speak to them, and carers, think they're on too many medications. I am about to talk to a PPI group, patient and relative experience group in Hull, about what they think about what we've done and how we can adapt it or change it. And the last question is quite interesting, and I'll spend a couple of minutes on it. It's about vitamin D. So I think especially during COVID, everyone was put on vitamin D, and for prophylactic purposes. So the argument we often heard was, well, if vitamin D is obviously not causing much harm, so why not just continue it? The evidence for prophylactic vitamin D use is not strong, and that's what the guidelines draw on. They've reviewed the evidence, and there's not much benefit for preventing any kinds of medical problems or fractures for prophylactic use. This is different to if you've measured someone's vitamin D and it's low and we need to replace it. So that's when I think Jess is pointing out that we're looking at the 4 ethical values: non-maleficence, do no harm; beneficence, do good; justice. And and autonomy. So obviously we're not doing much harm. The beneficence, there's not much evidence we're doing much good, but the argument is, well, if we don't know, we might as well give it. And this is where it comes down to the principle of justice. And that refers to the fair and equitable distribution of burdens of benefits to participants in society. And healthcare is associated with limited resources. Carbon reduction and sustainability principles are important for everyone's health and welfare. And there's an opportunity cost when medications are used. And actually, so, we do as physicians, I think, need to consider the wider implications of our prescribing. And separate to that, we've had a lot of feedback from the actual ward teams, nurses, pharmacists, healthcare and support staff who are giving the medications. It massively reduces the workload for them if you're taking away medications like vitamin D when there's not much evidence for their benefit.
It also helps us focus on the medications that were really benefiting that patient. So in a patient with advanced dementia who's quite confused and struggling to take any, really focusing on the ones that we know are going to give them benefit and enabling the team around that patient to do that was really helpful. And we also found that some patients were on a medication that symptom had historically resolved, but then because the medication hadn't been stopped, they developed side effects. And then they were on a medication to treat the side effect. So then you found actually you could stop 2 or 3 medications because the original thing had resolved in the first place. And we on the first ward that we worked on this project on, we didn't have any family members disagreeing. They were welcoming reducing the medication, saying, "Oh, my mother's been on that for years. I don't even know why she was prescribed that when she was in hospital. It's never been reviewed, and now she's on something because she's getting side effects from that." When actually, when you work back, a lot of the time these medications were intended to be reviewed within 6 weeks, 8 weeks, and things get missed very, very easily. A busy hospital, busy GP practices, the patient's discharged, they're left on that medication without a review. We also found that anecdotally, people were starting to feel better because they were on less medications, so they were getting less side effects. We don't have the research on polypharmacy. How does vitamin D interact with mirtazapine? How does a statin interact with zopiclone? We don't have that evidence. So in looking at that first point, people were feeling better because they weren't on medications that they didn't need. And in fact, I find it a form of discrimination to not be reviewing these medications really carefully and thinking about everything that we're giving an individual, particularly somebody who has a frail of the body, where these medications can have a massive impact. Thank you. Sorry.
Yeah. No, thanks, Catherine. Yeah, no, that brings it into kind of more clinical context. And I think the take-home points from this is that although it seems like quite an obvious thing to do, an intervention, the effectiveness of it is an indication that it's not being done like this as it is. So we do really need to be driving these simple things forward. It's not so easy to do that, even though it seems easy that doctors should be making decisions on de-prescribing medications. There's so many factors that go into it. And so formalizing interventions and adapting them as we go on and researching them and targeting them for the appropriate population you're using is important. There's a huge drive for de-prescribing. Currently, 1 in 11 people over the age of 65 have dementia, and it's predicted to be 1.6 million people by 2050. So although you're looking at a very small select population, inpatient dementia, a lot of people are going to be passing through this. And there's also opportunity for the tool to be expanded into care home settings, into hospital settings, and maybe at the point of diagnosis and GP settings. So there's huge potential with this. And just a very quick, messy slide on going forward. We do still need to keep looking at this intervention. What we didn't do before, is not related to this slide. What we didn't do is measure outcomes. So we didn't measure safety things. So did someone then have a blood pressure drop, or, did they get admitted to a physical hospital? The reason we didn't do that was, one, was pragmatic and practical, but two was that we're using already clinically approved guidelines and following them for medication management. So we didn't see the need. These guidelines have been tested well. Anecdotally, there weren't any problems from the 3 wards. I'm kind of, when we test these interventions going forward, I'm in 2 minds about whether we should be including those outcome measures or not. And I think it would be good to get some wards where we do. What this slide is about is, we do need to, yes, it worked in Hertfordshire on these 3 wards, but different trusts are very different. They have different number of inpatient dementia beds, therefore the population of people being admitted to those beds are different. So we do need to know how big the problem is. So I'm working on a project to look at, big research databases about what medications people are coming in on and how many of them are potentially inappropriate. And then we need to explore from people with lived experience, carers, what they think of these interventions. We need to explore further the barriers to de-prescribing on inpatient dementia units, more qualitative work. And through this process, we can then adapt the tool, maybe not a stop frail tool, maybe a stop dementia tool, where we can really make this intervention more meaningful and effective. And then we can look at adapting it for different settings along someone's dementia journey. So diagnosis, GP care, home, acute admissions. So if we do all of that, then we can really, I think, maximize the impact from these kinds of interventions. So yeah, so that's it. And the main message here is that it makes sense clinically to be doing this, and it makes sense in terms of the environment and sustainability. So I really appreciate the Royal College for inviting us to present here. And if you want to get in touch with me afterwards, email me, that's my email. And if you're interested in doing this in where you are, then we can have a chat and we can arrange that. So thanks everyone for listening, and we're happy to answer questions.
That was great. Thank you so much, both of you. Really impressive work, and it makes total sense. And as you're saying, it really highlights kind of the co-benefits of this type of thing. It's benefit to the patient as an individual, but also to the world with regards to sustainability. So I would encourage people to put any questions you have in the chat box, because we've got a few minutes to open up the floor. I suppose I've been noting down a few things as you've gone along, and I have a few things to ask, if that's all right. I'll kick things off, and if anyone else has any questions, just do chip in. Where to start? I suppose I was interested to know what the kind of overall MDTs, including the kind of consultants, how they kind of responded to this, kind of both positive feedback and negative feedback, what their anxieties about it.
To be honest, it was one of the pharmacists on the first ward who brought it up. Was like, this patient is still being prescribed and issued this medication, and they haven't taken it for weeks. Like, why is this medication still on the drug chart? And to be honest, we were too scared to stop it. We're like, well, where did that medication come from? Who do we need to speak to? How do we create a structure around stopping this? Because it was very sensible pharmacists who were saying, why are they still being issued this medication? So when we found these guidelines, and that gave us the structure to stop them. And also, again, from the nurses issuing the medication, saying, look, you know, if we're lucky on a good day, this patient will take 2 medications from us, or which one do we need to focus on here? And actually, we thought we're doing these people a disservice by trying to give them something which we have no evidence will benefit from, when there's a couple that we really need to give them. We had a really positive response, to be honest. The most concerned I found were the GPs, because they were worried. Like, I haven't seen this patient, I haven't reviewed, and they didn't have the time, because they are so stretched, to go through all the patient history and find out where does medication start and are we safe to stop it. So when we were saying that we're going to make this decision in our MST, is that okay? Sort of that way round, we got much more support. And what we found really helpful was that sort of day-to-day experience of the patient in making those decisions at the start. Can we include this patient? You know, because sometimes somebody would say, the consultant might say, this patient's got years to live, and the nurse on the ground will say, actually, they've been really deteriorating over the past 2 months. I really wouldn't be surprised if this person wasn't with us this time next year. So we had a good, it united everybody, I think, and we really made sure that we were listening to any issues that came up, and discussing with families, and involved everybody, because it is everybody's job, we felt, and included an MDT approach.
No, that's really interesting. So it sounds like, if anything, it kind of improved communication generally between staff and families, and GPs, from the sound of it. And that again links to the question I had about the GPs. So was the feedback that you had from GPs during this, what did they say generally about it?
I felt that on the whole they were happy for us to make the decision, but they didn't necessarily want to be involved in the decision, because they didn't have the time and resource to go through all the patient records for that patient. So if we were saying, well, we've had an MDD discussion and we've decided to stop this medication, that was fine, but trying to involve them in that decision was just practically very difficult.
Yes, no, that makes sense. And there's a really nice comment in the chat here. So great to hear this. I work with adults in mental health settings. So much polypharmacy drug interactions is a very under-researched area. And I guess that's where it's great that you've used the kind of evidence tool to get the ball rolling on this. I think that really gets people on board. I was also going to ask you about kind of what were the main barriers to getting this going, but also the kind of key facilitators, if you like, to getting this work off the ground.
I think Catherine was quite a key facilitator, because you're approaching it from that sustainability angle, and it's just an extra energy, it's an extra drive to get this work done and get this good practice pushed, because I guess we've all been thinking for years polypharmacy is bad and we need to do it for our patients, but having that extra, sometimes I guess you're doing things for patients all the time, having that extra push of saying we're also doing this for our system and for our healthcare system and for everyone, is an extra push. I would say actually the pharmacists were really enthusiastic once we had brought it up. They really were the most enthusiastic people. But one of our consultants on Dr. Walker, right, Catherine, he was quite keen as well. And that's where you have a consultant psychiatrist that is quite keen to de-prescribe, even, and to delve into the physical health realm to do it. So he, as an individual, was also quite important.
That then gave us the confidence to take it to the other wards. I think once we've done it on our own ward, then taking it to other wards, we have this sort of basis. This is what we've done. It's worked. We're confident now to carry on. Yeah,
so we'll have a snowball effect, because where you have other leaders in other wards that might be resistant to go near some of the medications or make these changes, if you've now got, one team that's done it, and look, here's what we've done. Now we've got 3 teams that have done it. Then people just start getting more comfortable with the numbers. And I hope it's a bit more of a snowball effect where each time it'll be easy to logically argue through the resistance. Yeah, because now I can kind of predict what people are going to say as well with all those FAQs. So I have an answer for everything.
Yeah, I can imagine. So it sounds like having a few kind of key, more senior kind of leaders in the area, along with emphasizing that this is not only good for patient care, but it meets our kind of green, sustainable agenda, kind of having those 2 things together and then just kind of pushing it through and just demonstrating the benefits, showing people that it works, seem to be really positive. Great. I'm wondering, I've noticed in the chat box that, is there, Chandra, do you have a question that you wanted to post? I can't see it if there is, but do put it in the chat if there is another question. Okay, no, nothing there at the moment. I was going to ask if there was there ever a time where you had situations where you just didn't know whether to stop it or not? And I know that you had a high threshold, for just continuing the medication if there was a query, but was there anywhere that you could go and take those queries to kind of medical specialties or anything?
Yes, a couple came up with diabetes medication. What we would do is, we needed some more blood results back. Then we would go away, do those investigations, and then depending on the result of that, come back, and where we need to speak to the diabetic nurse specialist or the GP, and go that way, really. So yeah, it did come up a few. We couldn't always make the decisions there and then in the ward round. We needed to gather a bit more information, make sure what we were doing was safe and that we had the numbers. For example, if we needed to check the blood pressure a few more times before making a decision. And then all those blood pressures were continued to be measured whilst the patient was on the ward once a day. So if issues arose, we can address those if they come up in the future.
No, that's great. That makes sense. And it's really nice that in this setting you do have the time to do that and to think a bit more clearly about these decisions, and to make sure you're making kind of nuanced choices. Great. Well, thank you again to you both. And yeah, it's just been really interesting and to see the work you've been doing and how it can be really done across the board, across the country. So that's really great. I will, anything final from you two before I move on?
No, just I think thanks for having us. And please do get in touch by email. So yeah, thank you.
Great. Okay, perfect. So we'll move on, if that's all right, to our second really interesting talk today. So this is coming from Neil Cross, who is the lead on property and sustainability for Birmingham and Solihull Mental Health NHS Foundation Trust. He has had over 20 years experience in waste management, with a very impressive CV and set of credentials in this area. So working in a huge range of settings, including government office for the West Midlands, supporting local authorities to achieve the best value performance targets around recycling and composting. Spent significant time with central government, developing the National Waste Strategy for England in 2007. And then within the NHS has led a programme of work that's enabled the Trust to win a prestigious Health Service Journal Award for green and the green sustainability agenda. More recently, as well as his day job, has been working as a theme expert to the ICS on its green and sustainability agenda, helping to develop its green plan and governance structure and reporting. And food waste, which is the focus today, itself represents just one small but visible and important initiative within the Trust. So I will hand over, but just as a reminder, do as we go along, put any questions in the chat box, and we'll come to them at the end, and Neil will be more than happy to answer them. So yeah, take it away, Neil.
Well, good morning, all, and thank you for the opportunity. Very difficult to follow that from Barrett to Catherine, very in depth. Most of it I didn't understand from a clinical prescribing point of view. I'm afraid mine's far more simplistic, but we all use it every single day of the week. We enjoy it, and we very often probably throw it away. That of food waste. Just a little bit of context. I work for Solihull Services, which is a wholly owned subsidiary of Birmingham and Solihull Mental Health Trust. I've been with the trust for many years, 17, 18 years, I think now. It's a big trust, one of the biggest mental healths in the country, just in terms of size, something like 700 beds, over 50 sites, these including medium secure units, low secure, acute. I'm going to check my list to make sure I don't miss anything else. CAMS, children and adolescents, community, older adults, specialists, eating disorders. So a complete range of services. So whilst we mention food and food waste, food being very different in very many of the environments, some of our sites with male forensics, they can't have enough of it. Other sites, and obviously we've therefore got obesity challenges, and other sites with people, as I say, with eating disorders. So very complex, very real. And I suppose 4 key words that spring to mind will be that of carbon, reputation, quality, and cost. And I think we need to keep those 4 in mind as we go through. Next slide, please. Okay, so just a little bit of further context. We have our green plan, a 4-year plan in line with the NHSE timescales for likely review in 2025. In that, we've tried to incorporate many of the key messages, but we also try and stop and think. We all see weather extremes. Some believe they're due to climate change, some don't. I'm not going to try and convince you. Everyone will make their own decisions on that. But what is clear is the devastation that is caused by weather events generally happens in those that are actually already the hardest hit. The communities where people are struggling, be that within the UK or overseas, generally become the hardest hit when we get weather extremes. Many reports suggesting that there are direct links between climate change and mental and physical health and well-being. I personally believe that there definitely are. I can think of many examples. And just in context, with us all on this screen today, we've saved travelling, but we're all using power. And the moment the world, or effectively the UK, is using 2.5 planet Earth's worth of resources every day. So we're using 2.5 times what we should be using in what we do. Legislation, and I should have put a capital R really before to reputation. We're public sector bodies. We've got a responsibility to do right and to lead. Next slide, please. It's important, however, although I've just said all that we do put it into context. We've only got a limited resource in NHS land, as we all know, and we've got to look at where do we focus, where do we put our resource. And this, you'll notice, it doesn't include medications, because I thought it'd be wrong to follow the previous one and put the cost of pharmacy in terms of carbon, but just in terms of our waste, our power, our gas, our travel. Waste is about the smallest. So when we're looking at what do we do, how do we measure it, what focus do we give, in 2022-23, we only looked at somewhere in the region of 39 tonnes of CO2 for waste, and yet 5,000 tonnes for gas. So we've got to make it work, but we've also got to make it deliverable and real. Next slide, please. Okay, so considerations, regulations, the trust itself. We're a big trust with a lot of staff, very high churn rates. So therefore, what we do has got to be simple, it's got to be deliverable. It's not the priority. It's not on top of everyone's list. Patient healthcare, patient well-being is such. The food waste is a byproduct of that health and well-being. but it can also help people get better if it's done right. What did happen? What needs to stop? So we'll look at what we were doing before. Is there a challenge, or are we creating one? Just because we're told we've got to recycle more and compost more and reduce more carbon, are we creating ourselves a challenge that we actually can't deliver? What was the impact we were looking for? Obviously more than one. And what's the desired output? And I'm very much in favour of the 90-10, the 80-20 rule. Are we ever going to capture the apple core that someone's eating as they walk down the corridor? Sorry, the apple, the core wastage that someone's eating as they walk down the corridor. Are we ever going to capture every bag of crisps? No, we're not. This was about focusing on specific areas. Next slide, please. Okay, so now we're thinking then of the overall cycle. So the project, we pulled a project team together and then started to look at where does it start? So it starts with, if we ignore menus for a moment, it starts with what we order. Are we over ordering? Are we ordering too far in advance? Do we share? Have we got any mutual aid in place between sites? We're not an acute, so patients don't normally come in and order their food on day one for day two. Yes, we have emergency admittance, but generally we've got longer stay population where we can get used to diets, but also diets and menus can't become boring. They've got to be interesting to some patients, as I'm sure you're aware. Food is the highlight of their day, and actually doing some themes specific, Christmas Day pizzas, you know, fish and chip Friday. It's the sort of thing a lot of patients want. Then we've got the delivery costs. Every van that takes food to every site is a cost. So it's all very well buying green from one and eggs from another and meat from another. You might be getting local sourcing, but actually in an area where a number of our sites are really near the climates at the CAZ, and with the challenges on roads, networks, gridlocks within Birmingham and Solihull, actually we've got to think about delivery. I've mentioned quantities. The two go hand in hand, quantities and quality. If we overorder or underorder, we don't get the quality that we need. If we don't get to the right suppliers, we don't get the quality. But are the right suppliers giving us what we want from in terms of our carbon life cycle? What are their credentials? I mentioned the life cycle of products, and of course, obviously, in the end, the waste itself. Do we actually know what waste we've got? And as other slides will show, we don't really. We're getting better now, and we will know, but we haven't got resulted data I can share with you because we're only really now setting our baseline. And there's a certain horrible piece of equipment that I'll mention in a moment that's caused that. So 3 key areas. We do 2 types of meals, one where we prepare it and one where we buy it in, either cook, chill or cook, freeze. The biggest volume, the biggest number of meals are served by our preparatory kitchens. So therefore we thought, let's start with prep waste. Let's look at what comes in, what do we waste? Why do we throw so many potatoes away? Why do we throw so many carrots away? They may have been used in meal 1, but could they be used in a carrot and coriander soup the following day and change the menu around instead of just throwing it away? Then there's the serving point waste. So what do we take to the wards? Very often our patients can't visit the kitchen areas, can't visit the canteens, the bistros, whatever word we use for them. So we've got our kitchenettes, so kitchen areas within the ward areas. What do we take there? Do we take the right quality? Do we take the right choice? And do we take the right quantity? When we dish it up, do we dish up the right amount? Is it actually what the patient wanted? And does it taste good? And how do we know that? We either know that through feedback, we know that through what is ordered, or we know that through what's wasted on the plate. So in line with what we're required to do through NHSE, we've set up a system for weighing and measuring our preparatory waste, our service point waste, and our plate waste. Next slide, please. So some of the risks, I put risks, but actually these are the risks, the assets, the challenge, Safety. Safety is obviously a risk, something we had to be very careful on. I'll go through the system, but basically we're moving food through the hospital to a ward, but then from the ward back out of the building. A double risk, slips, trips, falls, most common form of incidents within the hospital environment, and yet we're taking potentially liquids and grease down corridors. Staffing, as I've mentioned, massive churn rates. So it's all very well training staff and educating staff today, but how do we keep this real tomorrow? Financial, there's an extra cost for segregating waste. Yes, if we can reduce waste and improve quality and reduce over-ordering, actually there's a much bigger gain. But initially we had to recognise a financial risk. Contractual risks, we've got 2 PFIs. Food waste isn't in the PFI. That had to be dealt with contractually. Green, yes, we want to be green, but we want to be green because we are green, not because we're seen to be. And I come back to, if you've got an extra vehicle going to a site to collect an Asda-size bag of green waste, that's not green. That's actually, even if the vehicle is a low energy vehicle, the congestion that that vehicle places on the road as an extra vehicle will cause other vehicles to be stationary longer and actually a knock-on effect. So we wanted to make sure that what we did had materiality and not just ticking a box for the sake of it. Compliance with NHSE and other guidance, compliance with waste regulations, compliance with our own quality controls, and making sure we didn't jeopardise the integrity of the organisation. Quality, in terms of quality improvements, the risk is that we don't improve. The risk is that we have data and we don't use it. Reputational, I don't think it looks good to see, especially where we have visitors visiting our hospitals, commissioners potentially coming to our restaurants and seeing loads and loads of food just being put into bins and disposed of. It's not good practice. We need to change that. And change. People fear of change. And the system we were going to implement, however simple, was such that people would have to change what they were doing. Next, please. Okay, so again, getting the right people, the right place, stage by stage. So we had a project plan. I'm not one for doing plans for the sake of it, but making sure we could identify who was needed, when they were needed, and what they needed to make it as easy as possible. I perhaps should have put on there, and my apologies, pilot, but we didn't rush out and do every hospital at the same time. Timing, it was about a pilot first of all, then a secondary pilot, and then starting to roll it out. A clear output, we've already discussed. The ability to listen, work as a team. Simplistic things. There's no point asking units to start doing something and then asking them to get their own scales and trolleys and caddies. Can you imagine what you'd be left with? This was about buying it all up front, getting what we needed that was right. Planning and investment. We haven't invested in machinery to compact our waste or to spin it and drain it, because we see that as actually money not well spent. The priority has been about a new symbiotic program we've got to actually capture the data, let the data feed back to the kitchens and the ordering, and let the menus and the quantities drop to try and reduce the waste, rather than spending the money on machinery to actually deal with it. And that obviously links back to where I started, to software intelligence and data that we're only now starting to get as real baseline data. Next slide, please. So the process, we're ordering the food. We've obviously already agreed what we're having. We're ordering the food by our catering staff. So there's one team involved. They've got to cook it, so effectively put it into trays, etc., to take it towards. So we've got our preparatory waste. The food's then delivered to the wards. Well, that's delivered by porters or healthcare assistants. So we've now got 2 more teams involved. It has to go in clear bags because the contractor won't accept it if it's not in clear bags. It has to be weighed so that we know what weight have we got in terms of preparatory waste. We then thought, well, okay, in clear bags, all that's going to happen is they're going to tear through the hospital, and then we're going to have loads of spillages. So caddies were bought, but caddies had to fit the pot washes so that we could clean the caddies. Caddies also had to be not too heavy when full. Cleaning, so we're now bringing our domestics in for additional cleaning, for dealing with spills. Then we've got to provide the internal bins to actually capture the waste. Then we've got to work with the contractor to make sure we've got the right systems outside to receive the waste for it to be taken off site. We've got to be compliant. We've got to understand our data. We've got to look at our menus, and we've got to look at our food ordering and go back through that cycle. And that's just within the preparatory kitchens. We've then got exactly the same at the serving points and at the plate waste side. We've got to engage patients at plate waste side and ask the patients to make sure they put the waste into the caddies and not into the black bin bags. So we're now trying to educate the patients to actually be more responsible with their food. Patients, healthcare system, there's more domestics, more poultry. It's a big team of people. What sounds so simple in just recycling food waste involves so very many people. Next, please. So as I said, the data and therefore the outputs are yet to be quantified, mainly because we used to use those horrible things called macerators. So we never measured our food waste. It was generally chopped and put into the Severn Trent's finest sewers, blockages, fatty products. In, I think it's Wales and possibly Scotland, they're illegal, you can't use them, but still in England you can. But we've now completely stopped. We've cancelled contracts, we're no longer buying them, we're no longer maintaining them. That's been complicated with 25-year PFIs, but we've dealt with it. We're now at a point, because we're not macerating our food and now we are weighing it, that we're starting to get our baseline. Because previously, any trust that says they've got a food baseline and has also got food macerators just simply cannot have it. We know we are recycling our food waste. Ours goes to anaerobic digestion predominantly, which for those that don't know, creates a mixture of heat, compost and energy, allows it to be reused, is local, and it's something that unfortunately we just don't have capacity to put on our own sites. We have already started to review menus. The symbiosis program that we've got running is already looking at food quantity and food ordering, and comparing that with the waste data that we're starting to put through. We think we're starting to reduce food waste, but we don't really know. Being truthful, it seems to be going that way, but is it seasonal? Is it just by fluke that we've got a better menu at the moment? We'll wait and see. Financial savings, I've put it on there, but actually to me, and others in the trust may disagree, but they're not the driving force, they're not important. What is important is getting it right, and if there are then financial savings at the end of it, then that will be a benefit because money we can reinvest. And obviously we will be measuring the environmental impacts of what we're doing. Next one, please. Okay, so that's our main sites, that's our biggest sites. That probably accounts for between 400 and 500 beds. But we've also got a significant portion of the estate that's on cook, chill and cook freeze provision, where it's meant to come in portion sizes. It's ordered based on previously agreed and pre-agreed menus, with obviously a little bit of wiggle room for new admissions, etc. So we're hoping that we get less waste, but there's complications because very often these come in tin foil or plastic trays. We've now got those to get rid of that won't go in the composting, and we haven't yet got a suitable route. Yes, there's a metal value in the tin foil type ones, but the number of trays you've got to get a ton of tin foil, I have no idea where we'd store them. So we've got a number of challenges to look at. We are looking at the menus. We've obviously engaged others like our dietitians. We've got a food safety group. We've got a food sampling group, which involves carers, staff and patients to try and get the right blend of meals. And we've got to continue to capture our data and make it work for us. Next slide, please. I thought I got one more. There we go. About 20 minutes we started. Any questions?
Great, thanks, Neil. That was kind of fascinating, and I've never thought about the kind of real details of how you manage such a complicated system like this. So you've given me a lot to think about, and I've written a few things down, but there's a comment here which I'll read out. So great talk, Neil. I love it that someone has thought through this complex trail in so much detail. I'm lucky enough to work in an inpatient unit where we have a kitchen on site, and last year we started collecting disposing of food waste separately. I'd like to know actually what happens after it leaves us, something to follow up. I found that patients are amongst the most keen and proactive about recycling, including food waste. I don't know if you have any comments on that, Neil. I think that what does happen to the food?
If the contractor's doing it right, there's generally 3 normal routes. One of those you probably won't like so much. One would be some kind of windrow or open composting. The second would be anaerobic digestion, not in any order, but the other route, anaerobic digestion. The third, believe it or not, would be waste to energy, which effectively is incineration. Then you're thinking, well, why are we pulling it out for that? I'm not a chemist or a scientist to know the answers to this, but for instance, an anaerobic digester has to have a mixture of green waste, food waste, liquid, and cardboard, etc. type of things to actually get it to work properly. And if that anaerobic digestion area, that's contractor, has got an oversupply of food, they will have regulations about how long they can store it for, and obviously smells, etc. If there isn't any capacity in composting, then the backup plan of all of these contractors is generally waste to energy, because at least you're getting a heat and a power source out of it. So I know with ours, we try to get it to anaerobic digestion, but we do have to accept that where they can't receive that, it will go to waste to energy. And if you like, that's replicated by those that live in Birmingham, plenty of the local authority. You segregate your waste at home, the local authority will tell you it goes for recycling. That is not entirely true. Of your waste at home, it goes to recycling where there is capacity still to recycle it, where the supply chain is still in order, and where it's being collected. But where capacity is reached at any single sorting station, then generally the backup plan of local authorities, which normally is linked to PFI contracts, is actually to put it through waste to energy. So I'm afraid even what we do at home, I know Birmingham, a proportion of my waste, not every week, but some weeks will go to the Tyseley waste to energy incinerator, purely because of their capacity to segregate and store different waste types.
That's really interesting. So I think, yeah, it's been a response saying, brilliant, thanks for the answer. I'll ask about what our contractors do. I'm sustainability liaison with patients, so all info is good to take to the table. And it's interesting about kind of the mentioning of the patients being kind of really keen on this. Has that been your experience, Neil? Have you had interactions with patients, carers around this?
Yes and no. And we everyone on the call will obviously know it's a very, very challenging environment, and we've got specialty groups of patients who are actually in there because of eating disorders. Well, politely, they're not really interested in food waste. If we go to some of our medium secure sites, especially the male, excuse me for being stereotypical, but it's the truth, the male medium secure sites and male acute sites, the biggest problem we face is criticism that we don't give big enough portions. Because the food's the highlight of the day, and we've got to be careful with health and well-being and obesity strategies and, you know, physical health, not to overfeed, or, you know, our dietitians try and sort the menus out. Some groups, certainly in the rehab side, some of the day patient side, I say probably the rehab's the best, where because they're given money to also buy in their own food, they are more conscientious about what they buy and how they dispose of it, and also about wasting less. You know, you wouldn't expect an inpatient 12, 14 bed rehab unit to have much pizza waste on a Saturday night when the patients have actually bought their own pizzas. So there are differing groups. It's not stereotypical across the organisation. And I just saw a question pop up about the anaerobic digester.
Yes. Yeah. I was going to ask about that.
A proper big one costs millions. They need sizable grounds to sit in, to receive the waste, to sort the waste, to put it through. Obviously, a lot of air controls because of methane and other smells coming off it. A lot of water controls because of drainage and entering storm drains obviously is a no-no. So they are very complex. So you would need to, your waste contractor would either have one themselves or would have turned to a third party for a residual contractor. I wouldn't have thought it's anything that most NHS trusts, other than perhaps through a PFI or equivalent if they've got the rural grounds, would consider. I do think, however, there may be one in Oswald Street linked to that trust. I think they used to have one in their grounds that they paid for through a PFI, I believe.
Okay. Yeah, no, that's interesting. I've never really thought about where that process actually takes place and what journey all this waste is going on to get to these places where it's going to be finally kind of used. Yeah, if anyone else has any further questions, do put them in the chat. Like I said, I've written a couple of things down. You mentioned it sounds like a big challenge is kind of how this is all measured, and there was a term like symbiotic program that you mentioned, and I was wondering what is that and how does it work?
It's basically it's a piece of software linked to handhelds that are being used across now the estate to record the weighted data so that the same software will link to the PC system, so we'll know what's been ordered and what quantities. We can then map what the wastage is. It's used for cleaning standards. That it's above me in technology, but we're hoping it will start to give us, if you like, red alerts as to where we've got a greater percentage of food waste per capita or per quantity given. It is very early days. The actual process that the handhelds have been in use for about 4 weeks, so it's very, very early days. But we're hoping it's a step forward. What we've tried to do is invest in that because we can use it to domestics, to cleaning standards as well, in the state's maintenance works, reactive works, etc. We've tried to link it to that rather than buying. You can buy machines for big production kitchens that you put your food in and it sort of spins it and compacts it and the liquid goes down the drain, and then you get a block of food waste which has generally got less water content, making it lighter and therefore obviously saving your cost per tonne. We haven't tried to do that at the moment. We're trying to spend our money on looking at what we provide and reducing it first of all.
Yeah, that makes sense. Like reduction is one of the key kind of principles of sustainability, kind of reducing use. There's another question in the chat. So has any consideration been given to the donation of unexpected food waste to staff or local food banks, etc.?
Oh, there's loads. There's literally loads and loads and loads. The staff one has been so confrontational.
Really?
Yeah, very, very difficult. With historically accusations of, are we over preparing so there's more meals, so that more meals can be given out. We did in COVID. We did free breakfast for staff. With the idea of supporting those that really needed it, but what does someone look like that needs it? What's that member of staff look like that actually really, really needs that? And we know that we had, very senior people in the organisation who you would probably stereotypically suggest didn't need it, benefiting from it, and others not because they couldn't get off the ward. That's been very, very challenging. something, yeah, it'd be good to do. We haven't done it with food banks. It's a valid point, it's a valid thought. I'm just thinking logistics, how we collect it from 50 sites delivery. But yeah, that's a valid point, and that is a valid point. But staff was a nightmare, absolute nightmare.
Really, that's really interesting. Yeah, trying to kind of make it kind of equitable and fair across the system must be really difficult. Okay, it sounds like you've been thinking about like working with the dietitians to make changes to the menus and things. How has that been going?
Sorry, I try and answer every question honestly. I don't really know.
That's
Because
okay.
I'm party to those conversations. That's all our catering teams. Politely, I have to give 20 minutes a week to food waste because I just don't have time to do any more. But what I'm led to believe is that they are sitting around tables, they are looking at the quantity of it and the quality, because we do recognise on all the patient feedback, carers feedback, that, and I've said it before in this presentation, but food's one of the highlights of the day. If you're not allowed out the ward, other than to an internal quadrangle, what have you got to look forward to? And one of those things is what the meals that you dished up. So quality is really important to us.
Yes, definitely. And someone's made a comment here, so how they've asked about the food banks, kind of what we were talking about before, kind of whether things can go to food banks. But ready prepared food was not accepted locally, which is interesting. Yeah, I guess that's might be one of the barriers you come across. Talking about kind of barriers, facilitators to kind of getting this work kind of going, was it something that it sounds like there has been lots of difficulties, but is there anything that was particularly kind of helpful, or tips that you'd recommend to those who work in this area within trusts?
Keeping it real and keeping it small and making it easy, I suppose, if I had to just really sum it up with one line. Meeting the right people on site, on one site, working out from effectively cradle to grave how we're going to manage it, buying what we think we need, and then we realised the first lot of caddies we bought, for instance, were too small. The next lot, believe it or not, were too big. Training, we had one member of staff, so there's a big saucepan, huge saucepan full of bolognese or soup or stew, whatever it got in it. And instead of tipping it through a colander to get rid of the liquid and then taking the solids and putting it in the caddy, just basically poured the whole saucepan into the bin bag in the caddy. So suddenly now we're paying for basically liquid disposal, water disposal. And then we're creating so many risks. So it's just about testing it and just the simplest thing, which scales work, which scales have got a big enough platform to put the bags on without being too big. So once we've got the right products, then we ran it at one hospital, waiting for it to work. And then I suppose my job became easier because it was agreed that if you like, the portering lead at one site would speak to the portering lead at another and give them the process, so that actually it was people with a like-for-like mindset that dealt with it. And it's been challenging, but it hasn't been as challenging because we've had the right people involved.
And I'm wondering if the people who work in this area within our kind of health system, if they're wanting kind of more details about these things, would it be okay if they contacted you? So it sounds like you've probably over time really picked up specific knowledge about what works, what doesn't.
Yeah, no, I'm more than happy to. As I say, in comparison to the previous presentation, it's very small fry, and its impact on carbon is far less than your pharmaceuticals, but it's important and it's real, and people like to see things that are real.
No, I think it's incredibly important, especially like you said, with food is the fuel for us, and it's something that people enjoy, as well as being something that's really important for your physical health, mental health. So it links across the board. It's not just the waste, but it's everything about it. So I think it's incredibly important just as important as the medications we give people, they need thoughtful choices. So does the food we give people, that needs a thoughtful choice as well. So I think it's very important. Great. I don't have any more specific questions, and nothing else has come up in the chat. There's another comment just saying how, from Catherine, who presented earlier, saying, I think this is hugely important, really inspired by hearing you speak, Neil. And yeah, likewise, this is an area that I, as a clinician myself, not given huge amounts of thought to, and about the complexities of it. And it's incredibly important. Okay, great. I suppose to kind of sum up kind of what we've heard today, I think it's been really great kind of food for thought, to use that.
Well done.
I hadn't planned that, I promise. But I'm just struck by how different kind of both of these areas are, but how they're both working towards the same aim of becoming net zero, more sustainable, thinking more carefully about our choices. They're so linked in that sense. And it again shows to me that this area really has something for everyone. So, whether you're a clinician, you're interested in prescribing, or whether you work more in the kind of recycling waste facilities area of your trust, there's areas to get involved in with that. And so how you can make a huge difference no matter which area you work in. And I think it's really useful to see how these things are working kind of on the ground, if you like. And these are such kind of specific and interesting ideas. It can really I really hope it triggers people to think, oh, what can I do? What can I do next? So we're going to share the kind of QR code, which is to the Knowledge Hub, which is where you're going to find all the kind of links to these webinars and further information about how to move towards providing more sustainable and green mental health care. We'll leave that up there for a second. I would also really encourage you to, if you haven't already, take a look at the report and the recommendations that are within it. And you'll see it's kind of laid out in a way where you can see kind of the different kind of principles of sustainable care and get kind of different ideas, and there's all kinds of examples and inspiration there, so I really recommend reading that. And alongside it, there's also the evidence document, where if you wanted to take more of a deep dive into how these recommendations were made, you can look there also. So huge thanks again to everyone who presented today and everyone who's joined. Do share this link with everyone and anyone that you meet, both at work and not, so we can get the word out. And I believe this webinar will be available to kind of watch for anyone that couldn't make it. So again, please do advertise that. So unless there's any other comments or any other thoughts that people want to put in the chat, I think we'll sign off there. Great. Thanks, everyone. Bye.